Yes, sorry. My name's Dr. Paul Richardson, and I serve as the clinical program leader and director of clinical research at the Jerome Multiple Myeloma Center, Dana-Farber Cancer Institute in Boston, Massachusetts. And I'm also the R.J. Corman Professor of Medicine at Harvard Medical School. Well, I think the context is very clear that those patients who've already been exposed and or are refractory to a CD38 monoclonal antibody, as well as exposed and or refractory to lenalidomide, constitute an area of exquisite unmet medical need, where certainly historical data would point to a median progression-free survival of around 6 to 8 months and a median overall survival that's just a matter of a year or two without successful salvage therapies. Obviously, the BCMA era has changed that somewhat, but this area remains an area of exquisite unmet medical need. What was very exciting about the study broadly overall is that we had eligibility for one or more prior lines of therapy. So there were actually 1 to 9 prior lines of therapy across the whole study, with a median of at least 2. Remembering that those patients had to essentially be quadruplet refractory usually, and the majority, as well as also BCMA exposed. So what we were very encouraged to see about this patient population was that our median progression-free survival was 18 months for the mezigdomide-carfilzomib-dexamethasone experimental arm compared to the carfilzomib-based control, where the median progression-free survival was 8.3 months, which was very similar to that seen in other settings, such as, for example, the Majestic-9 study, which was presented shortly after ours, where they had almost identical median progression-free survival in their population as well. So this control group behaved much as might be expected in the CD38 refractory setting, but obviously the mezigdomide-carfilzomib-dex triplet of the experimental arm exceeded our expectations with a hazard ratio of 0.48 and a substantial progression-free survival gain as a median. Well, that was very encouraging. We saw more neutropenia in the context of the 3-drug combination versus the 2. However, that proved manageable with growth factor support and dose reduction when indicated, although the dose intensity of mezigdomide was well preserved at around 83%. Earlier you asked a question about subgroups, and I think it's important to frame that out a bit more for you. If you look at our patients who had a median of 1 prior line of therapy, or had 1 line prior therapy, in other words, they were receiving this combination as a second line or first relapse salvage regimen, the median progression-free survival has not been reached. And so I think that's an important thing to share with the audience. In other words, it was highly active in the earlier relapse setting, but the consistency of benefit across multiple settings was one of the striking things in the trial. And in terms of the subgroups, we were pleased to see that in older age, in high-risk cytogenetics, in patients with extramedullary disease, in patients who were refractory to last therapy, we saw a consistent benefit, and there wasn't actually one of our pre-specified subgroups in whom the hazard ratio crossed the median. They all ranged from around 0.3 to about 0.6 in terms of their hazard ratios for each of those pre-specified subgroups. That kind of consistency of benefit is quite striking.